Welcome today to Your Health. We've been a TV program now for about 8 sessions, and today we welcome. I'm your host, Bev Muendel-Atherstone, and I'm the chair of Lethbridge Friends of Medicare. And today we will focus on what the privatized American healthcare system really looks like from the inside. We are joined by Maggie and Chris Dabbs, who have just recently moved here from the U.S. Welcome to Canada.
Thank you.
Thanks, Bev. It's great to be here.
So where did you come from to Lethbridge?
Oh, well, we're immediately moving from outside of Chicago.
Yeah.
So about 40 miles east of Chicago in a smaller Indiana town called Valparaiso, Indiana.
Mm-hmm.
I'm originally from that area, Northwest Indiana. I grew up in Gary, Indiana, which is where Michael Jackson's from.
Gary?
Yeah.
And I'm originally from the southern United States. I'm from Oklahoma originally, which is where Chris found me working on his PhD and then brought me to the Midwest.
Yeah.
Oh, what a shock.
Yeah.
What a shock. Quite a change. Yeah. Mm-hmm. Yeah. So why did you choose Lethbridge, or did Lethbridge choose you?
Both.
Oh, yeah.
Both? I mean, it's for your work. What was the biggest reason?
Yeah. I got an offer of employment at the University of Lethbridge. Mm-hmm. So I teach in the counseling psychology program there in the Faculty of Education. So I was, I just did a kind of international job search, and University of Lethbridge really stood out. And so we're here primarily because of that, but there's other reasons that brought us here.
The United States is getting kind of weird right now. it's a weird time to be an American, for sure.
Yeah. It's a strange time to be an American with our predilections, I think, in particular.
Yeah.
So, yeah.
So you found Lethbridge, and you've been here a little while, a couple of months.
We've been here, about 6 weeks.
Yeah.
Mm-hmm.
Oh, so short.
Yeah. Yeah.
So how have you found a family doctor?
No.
We had a really interesting experience trying to find a family doctor so far.
Yeah, it's so I will say in the States usually like you call, and if someone is taking on new patients, you would just initially go in for like that first visit, meet them, see if it's a good fit for you. But here we were kind of surprised. It was almost like a job interview. It was like, fill out this application and we'll get back to you, basically.
It's kind of like speed dating almost.
Yeah.
Like we went in and filled in some information and handed in our application. And then they, like Maggie said, they said, well, we'll get back to you. And we haven't heard back.
We were able to get our scripts through a prescribing pharmacist.
Yeah, that is something.
That was different.
That's something different for us, is your pharmacists here have some level of prescription privileges.
Yes.
So we have been able to, maintain our prescription medications, but we haven't found a primary care yet.
Yeah.
And that may take a while.
That's
a while.
Yeah, that's what we keep hearing.
Yeah, we were warned of that before moving here. One of my colleagues said something like it could take up to 2 years to find a primary care provider. So we're, I don't know, we're waiting.
So what has surprised you so far? I mean, you're only here such a short while, so you don't know that much about the depth of the society or the culture. But what has surprised you so far?
Related to healthcare, like in general?
Well, in general, and then healthcare.
Sure.
Healthcare-wise, one thing that I thought was kind of interesting was we've made some friends through the university, and one of your coworkers' husbands is a gynecologist, and I was asking him about finding a specialist for that reason, and he was saying that primary care physicians do a lot more of like the general women's health screenings, and you would see a specialist more for like if there was something wrong, like if you were needed like surgical intervention or things like that. So that was different, because in the States it's like I've got my family doctor and I've got my gynecologist and I've got my whatever. So that was different.
Yeah, the scopes of practice seem a little bit different.
Yeah. Definitely.
Yeah. What about anything in general? Found anything in general?
You guys don't have frozen Pillsbury biscuits at Walmart. And the southerner in me is really sad about that.
That's true, yeah.
Oh.
Yeah, so there are some general things. I think, coming from the United States, and your viewers are going to laugh at this, but, we're working on understanding kilometers and grams. When I first went to the grocery store and went to the deli, and they were like, how much turkey do you want? I was like, I don't know. I have no idea. But that's that's American imperialism, baby.
Freedom units.
Yeah. And so there are some, there's things like that. The money is different.
Yeah, the money is different. Getting the the coins that have like a bill value is kind of different.
Yeah, $1 and $2 coins.
Loony and Toonie.
Yes. Yeah. Sometimes
we-
when people are giving me change back, I'm like, what?
Yeah, like we technically have dollar coins
Yeah,
in the
silver
States,
dollar,
but
the silver dollar.
yeah, but if you went to the dollar store and paid with a dollar coin, they
They
would
would be
look at
thrown
you
off.
like you had 3 heads.
Yeah.
Or they look at the date and see what was really valued.
Yeah.
Yeah, maybe you're giving away
Right,
$100 value.
right.
Yeah, for sure. Definitely.
Oh, people, I think generally people are very friendly.
Yes.
That's something, like, we actually made a joke on the drive here. We were we were at a crosswalk and all of the opposing traffic had stopped for a pedestrian. I was like,
yeah.
oh, that's novel.
Never would happen in Chicago, ever. They'd yell at you for using the crosswalk, for sure.
Yeah, so.
Yeah, we've heard that Canadians value like their personal peace, so politeness and just that general like being kind to your fellow man is just the
Yeah.
standard, which is really nice.
Yeah.
Nice. That's nice to hear.
Yeah, we have the stereotype in the Midwest of like Midwest nice.
Yes.
This
And
hospitable
the
thing,
South
but-
too, like
Yeah,
the Southern hospitality. So
Yeah, but we've really felt it here.
yeah,
Yes.
absolutely.
Yeah, real hospitality. You know, I think that's part of the prairies.
Yeah.
Whether it's the Midwest in the U.S. or the prairies in Canada.
Yeah.
Yeah.
You know, that was the way to survive.
Yeah. And you know, coming in as Americans, like rightfully so, Canadians are upset
Yeah.
with their neighbors. And so there was a part of us that's like, how are we going to be received?
Yeah.
Do we need to
Yeah.
keep it on the hush hush that we're American? But everyone's been like very, very kind.
Yeah, I've just been very upfront with people. Yes, I support Canada's sovereignty. And that's been received well. So
Very sweet, very sweet. Well, we're very happy to have you here.
thank you.
Yeah, and I
Thank you.
hope it goes well. I hope you enjoy your jobs, and you've got a job too.
Yes. So I'm a pediatric speech pathologist, and right now I'm working on all of my Canadian licensure, so I am still doing telehealth with a United States company. So I was able to continue that, which has been
Yeah.
good for us financially.
Yeah.
But
That's great.
Yeah.
That's great. Well, in speech pathology, you know, there's only 3 places in Canada, or maybe it's only 2, that give the speech pathology degrees. So
really,
yeah,
I
so-
didn't know that.
Yeah, so we're really fortunate to have you here.
Oh, thanks.
That's great. Okay, so when we spoke earlier about the whole healthcare system in Canada and the looming threat of privatization as
Sure.
our government privatizes more and more, you thought in our discussion you were saying you think that Canadians just cannot imagine the reality of the U.S. system, and that's why they're not afraid of it. So that's why I thought that it would be fabulous to have you two here
Sure.
to talk about the reality. So are there some very specific things that you think that Canadians just don't get?
Ooh,
Your hospital bill, I think.
Oh, yeah. So
Okay.
we can speak, I think, both personally as people who have lived in that system for our
Yeah.
entire lives, and professionally as
Yeah.
people who have, as healthcare professionals who have
Yes.
used that system. So personally, like I am still to this day paying off an emergency room bill from 4 years ago. So in the United States, and I don't think this is often talked about, or maybe it is in certain circles, your insurance is almost exclusively tied to your employment. So that's part of the private healthcare system we have. If you don't have a job, you often don't have insurance unless you meet qualifications for
Like a private.
either from the marketplace, so what is nationally known as like Obamacare, right? Or if you're under a certain economic level, you can usually apply for Medicaid. However, if you don't meet those criteria, then you're just insurance-less because insurance is tied to your job. So there was a point in time during my PhD training where I had finished my PhD right before I started my pre-doctoral residence. And so there was a week where I wasn't technically employed and I had to go to the emergency room. And
Just that week.
Yeah.
that week. And I got slapped with a multi-$1,000 hospital bill that
Yeah.
I am responsible for. And so I have been paying on it monthly since then.
Yeah.
It's one of the reasons why most bankruptcies in the United States are because of medical debt.
Yes.
There's also a lot of, I think, distrust amongst Americans because of that, of not wanting to go to the doctor
Yeah.
because they think like, oh, they just want my money. Especially with like, I think of your pawpaw, like the older generations and stuff like that, distrust is there because it's like, oh, it's just gonna, cost me an arm and a leg.
Yeah.
And there are so many people who would rather risk, potentially like dying.
Yeah.
Like, oh, I have chest pain, but like I can't afford to go to the emergency room. Giving birth, I think, is a minimum of like $25,000 in the States.
Yeah, that was going to be one of my questions.
Yeah.
$25,000.
I think minimum.
Oh yeah, I mean, you can, depending on the complexity of your birth, like if you need surgery and aftercare, I mean, you're talking hundreds of thousands of dollars to
If
give
you
birth.
look at like a bill, the thing that is the most surprising to me among my friends that have had children is, so like skin to skin, when they place the baby on you,
Yes.
that is considered a service. And I think my friend got charged about $175,000 for them to place her baby on her after he was born. That's part of the bill. Yeah. It's pretty crazy.
It is astonishing. Okay, so if you had a medical emergency and you had to have an ambulance come take you to the hospital,
yes.
how much does that cost you?
It kind of depends.
Yeah.
It kind of depends.
In the States,
$2,000.
a lot of people will just die.
Yeah.
Because
usually it's free.
Emergency vehicle services are often privatized. So we have a lot of private ambulance companies, and they charge thousands and thousands of dollars to come and take you to the hospital. So people won't use emergency services.
My grandfather once drove himself to the hospital during a heart attack, so he didn't have to pay for an ambulance.
Yeah. And in some states, you have to opt into using an ambulance. So when I moved to Oklahoma, for instance, and I was signing up for all of my health care through the university I was a PhD student at, there's actually a form that you have to complete to allow the government to charge you monthly for ambulance services. It's essentially ambulance insurance. And if you don't opt into it, the ambulances won't come to your address. So even if you're having a heart attack and you call in ambulance services, but you have not signed into this or opted into this program, sorry.
It's all very like money forward. I remember being an undergrad and having to go to the emergency room one night. I was having chest pain, and I'm by myself. I'm living in a city different from my parents. It's the middle of the night. I'm a kid. I'm scared, and they come into my room like while they're doing all these tests, and it's admin, and they're like, "What credit card do you want to use?" And I was like, "I don't know. I don't know if I'm having an embolism right now."
Yeah,
It's very It's this. I think both. I guess consumer would be the right word.
It's consumer.
Consumers and healthcare providers are very frustrated by it.
So you're not a patient. You're
a customer.
A customer.
Yeah. And us on the flip side of that as clinicians also get very frustrated because it makes you feel like you're restrained in a sense of what all you can do for your patients.
Yeah, insurance definitely dictates medical care in the United States. There's no doubt about it.
But on the other hand, if you don't have it, then you're screwed. It's even more expensive.
Yeah.
Well, and that leads me to another question. So, what do the poor people do? You talked about Obamacare, Medicare, Medicaid. So, who does that cover? Do you have to be in a certain category of poverty to be covered?
Yeah. So this is something I was actually thinking of pretty specifically as we were, preparing to talk about this. So I've been on Medicaid in the United States, which is for almost exclusively for people who are low income, but also people in protected classes like pregnant people and things like that. So I have been on Medicaid, and Medicaid in the United States operates a lot like the healthcare system, the public healthcare system in Canada, where it's funded through taxes.
It's state and federal, I believe.
So certain states have opted to make their own Medicaid programs, but it's paid for through taxes. There's no point of service selling, right? Like if you have Medicaid, it's often free, the services. There's no co-pays or anything like that. Medications are usually covered. Yeah, and so in the United States, people who tend to have Medicaid, they're actually working in a system that's a lot like the healthcare system here. But that's not everyone, right? And there's a lot of other socioeconomic distress that goes into, getting Medicaid in the States.
There's still barriers to their treatment,
of course.
So when I was working in a private clinic, I had a lot of Medicaid clients that came in. And I believe the first 29 visits to see me as a speech therapist were covered on most of their plans.
Wow.
But there's all kinds of hoops you have to jump through once those visits are over. So me as a speech therapist, once those visits are over, I have to write a full report on like progress, how they're doing, and then justify why they continue to need services. Insurance can say, no, they don't need that. Now, keep in mind, there's no healthcare professionals on there.
Right.
Now, sometimes there is something in the States called a peer-to-peer, where a insurance representative would call me and be like, well, why do they need these services? And I'm like, well, if you look at the 10-page report I just wrote you, and you have to convince them, and sometimes they still don't believe you, even though like I'm the professional in this sense. There's also like you have to, as a clinician, keep track of when those claims, progress reports need to be submitted. So I had a client that was on his 26th visit, and I thought, well, I'll go ahead and get the report submitted for him because it's going to take weeks for this to process. Medicaid denied the claim because it wasn't until his 29th visit. And at the 29th visit, they made me resubmit all of that again. And then, of course, there was a month-long lull in his care because it takes weeks to process it. So even if you do have the more, I guess, the equivalent of like the public insurance, there's still hoops that have to be jumped through where there's lapses in care, or some professionals, you could talk about this, aren't taking Medicaid.
So I think Medicaid, so like the public system in the States has been so weakened by private insurances that there are many professionals who just won't take it because it is so, like Maggie was just speaking on, there's so many hoops to jump through. The reimbursements are so low for providers. I actually still work for a clinic in the United States. I do, I'm a testing psychologist, so I do remote testing for things like ADHD and autism and learning disabilities. And the clinic I work for has actually recently stopped taking Medicare and Medicaid because there were so many issues with claims being audited and clawed back. So you'll hear this, I don't know if you have this terminology here, but
clawback.
Yes. So many providers, 6 months after the date of service, were having all of that income just taken back, right? And that is as a provider, that is an untenable system to work within. So,
and it creates this ethical quandary too for providers, right? It's like you want to help these people because a lot of times they're the ones that need the most help, but also you've gone to school for so long, you feel like you need to be, God forbid you be compensated for your services and all of that, but then, they're also not getting care, and it's just this.
And how much pro bono do you do?
Oh, I would say, okay, so.
No, but I mean, that was my question for the professionals.
Like, how, well, like what, well,
how
you
much
can
pro bono
still pay your bills. You mean, no, for sure.
Because some of us are ethically encouraged to do pro bono work, right? Like the American Psychological Association does give us an ethical charge to, do what we can.
Yes.
But when so much of our work is already being underpaid, that becomes an ethical dilemma too.
Yes.
Right?
Yes.
When an insurance is only paying me $200 for a 12-hour psychological battery, that's, I could make more money working anywhere else.
Yeah,
right?
McDonald's.
Sure, yeah.
For sure.
Yeah. So I guess you may have related to this already because you talked about the bankruptcies in the U.S. are mainly related to bills from going to healthcare. We've heard, we hear that the catastrophic illnesses like cancer and so on, that those are the main causes of these horrendous bankruptcies. Because when you have cancer, it goes on, and you need to be hospitalized, have operations, radiation, and so on. The list just goes on and on. So what do people do? Oh
man, I mean, we see a lot of like I call it like post-apocalyptic community fundraising. So like GoFundMe is really popular. When people are going through a really terrible emergency, they'll take to their communities, they'll ask for, community assistance through these private companies like GoFundMe. And you often see news articles pick these up as like, like these, like this
Timmy.
Or they present them as like, oh, look at this positive,
right?
Like this the community gathered around.
I
mean, in some ways, it's an issue, right?
Yes.
That that people have to do that
Yeah.
instead of just being taken care of by the system in which they pay taxes. So there's a lot of that. There's a lot of private GoFundMe type things, or people just, they use credit cards. I mean, the United States
lot of
is,
credit card debt.
I think, over $1 trillion in credit card debt. So people will run up their credit cards. Yeah, it's a lot of debt. And then they file for bankruptcy, which is paid for through taxes.
Yes.
So it all comes back around anyway onto the taxpayer. So.
Now, you talked about having a baby can cost as much as $25,000.
So
and a
much,
C-section, of course, would be even more expensive
Oh, sure.
going in. And so I'm wondering, are there midwives? Are there other opportunities for women who are having babies? Or do they just, if you can't afford this and you don't have Medicare, Medicaid, do women just have babies at home? Are we back to the, sort of like the before the 1800s, where you just have your mom and your grandma and your neighbor helping you to have a baby? I mean, what's actually happening? Do you have any idea?
I know there are women who do have midwives, but I don't know insurance-wise what that would cover. I doubt like a state program like Medicaid would do that. I think it would be more through your insurance or like private, but I don't know for sure stats on that.
I can tell you that all of the insurances I've had so far in multiple states, Illinois, Indiana, Oklahoma, they have never covered midwifery.
Yeah.
They don't cover that. Oh, no.
So as far as private insurances go, I'm not sure.
Yeah.
I do think this, I don't know a whole lot about this. I do think the statistic is that most women in the States, or most pregnant people in the States, are giving birth in hospitals.
Yeah.
Even though there is that, the debt that comes along with it.
Terrible debt.
Yeah. And I think part of that is just,
You have to.
Yeah,
What are you gonna do?
Yeah, you have to. It can be safer for some people, and so there's fear about giving birth at home, even though it could be a more economical situation. There are definitely people that do home births, water births at home, and they have their physician come in, but
I feel
almost
like,
assuredly those are private pay people.
Yeah, and in a way, I know you were saying like, or are they just giving birth at home because they don't have an option, but it kind of seems more like the home birth is more of a privilege. Like you're paying to have people around you that could help you do that.
So that's more that upper middle class.
I would
sure.
say so,
Yeah.
I'm going to have a home birth.
Yeah.
But that would be well cared for. You'd have professionals with you.
Of course, we're speaking in generalizations, but
at the same time, the stats in the U.S. show that infant mortality is highest amongst the poor and
women of color as well.
Yeah, and people of color. So that was exactly what I was going to say. I think that there's a whole group that's being missed in terms of what is actually happening in their healthcare. And I'm assuming that stats are not being taken. That's what we're missing in Alberta is we don't have a lot of the stats of what's actually happening.
Yeah. What's Alberta do as far as statistics for medical things? Like, do you have a agency that takes medical stats or?
No.
No? Okay.
Not to my knowledge.
Yeah.
No. So I don't know the data, the exact data, but I know that we don't know all the things that are happening on. And in Alberta also we have privacy of information. So in order to get information that maybe the government has, you have to get a release. It's called a FOIP.
Yeah.
It's called freedom of information. Sort of a 1984 term.
Sure. Yeah.
Freedom of information, which really means the information is not free, it's not easy to get to. It's very, very difficult, and then you might get it and it might be all redacted anyway.
Interesting.
So it's very hard to get information.
Okay.
Yeah. Okay. So it seems like we've gone back in time to the era of backstreet abortions by unqualified professionals, unqualified people. And I'm just wondering, so what is actually happening now?
I mean, people are having to drive incredibly large distances in order to get abortion care. It's definitely become, or people think that abortion is a very black and white issue, which of course we know it's not.
Right.
There's instances, there was a really big case of a 10-year-old who was the victim of sexual assault that was having to drive like 3 states to get an abortion in the United States because her state wasn't allowing her that medical care. So.
Yeah, 10-year-old. And I've heard also for women who are have compromised health.
Yes.
And because of their health concerns, they shouldn't be having a baby. Something's wrong.
There's that. There's also like ectopic pregnancies. There's examples of babies dying in the last trimester, and doctors
Yes.
being worried that they're going to lose their license if they take the dead fetus out, even though that could cause the women to go into like septic shock and kill them.
Yes.
Yeah.
Yes.
It's terrible. It's very Orwellian,
It's-
honestly.
we've regressed pretty substantially in that. Yeah.
So I was wondering also, what about people who have, pardon me, diabetes and need insulin? What about people who need life-saving medication? Is there any compassionate care for people who need something right away?
I don't know if the pharmaceutical companies would agree with that. No.
Yeah, no, I mean, insulin is a problem in the United States, and it has been. I mean, we've had CEOs arrested for, falsely jacking up the price of insulin.
We had a CEO of an insurance company murdered because of that recently.
I'm sure that
Not us. We didn't have that done. It happened in the United States. I'm sorry.
It did happen in the United States. It probably
Yes.
it probably made international news. I would assume.
Yes, I remember that. Yes.
Yeah, and so people who need life-saving care, they often don't get it, particularly if they have chronic illnesses.
Yeah.
Chronic ongoing issues. Getting treatment for that in the United States is very, very difficult.
So I guess my last question, because I see that we're running out of time, would be, what benefit is this to a government to have such a healthcare system that really doesn't care for the workers and the people in your country that you need for the next generation of just population? Of what benefit is this? Is it just that there's a need to pander to corporations?
Well, I think that there is a very real benefit in that people will get rich. I think that's the primary benefit of privatizing healthcare in a capitalistic system, is that there will be people in the top, the 1%, who will get filthy rich, and that's what we see in the United States. I mean, our private healthcare CEOs make hundreds and hundreds of millions of dollars a year on the backs of dying citizens.
Yeah, so I guess if Canadians have any questions about, like, is it better, it's not to say that, I know in the public sphere here there's difficulty with, like, getting access to a physician, and there's problems in every system, but there are a lot of invisible financial burdens that comes with a privatized healthcare system, for sure.
Yeah. So benefits to citizens, I don't think that there are many.
Yeah.
But
that's just us.
That's our opinion.
That's just two people's opinion.
Well, thank you very much for coming here, and we hope that you have a really wonderful stay in Canada and that you continue having a very positive experience. Thank you so much.
Thank you so much, Bev.
Thank you for
so
having
much.
us.
Thank you. Thank you for being here.
Of course.
Thank you.